shared decision making is obviously gaining interest in our specialty in thoracic oncology, especially because we now have multiple alternatives to propose to patients during our consultations. This applies in the early stage or in the locally advanced disease, as in patient with stage 3, but also in patient with stage 1. Unfit patient, now we have the alternative of SBRT, which in these high-risk patients could be a valuable treatment. So it is important to engage patients in the discussion, and obviously engaging patients mean establishing a contact with the patient and attend the consultation fully, and listen to the patient and to the patient perspective, values, background, and then provide that level of information which are appropriate to the patient. Basically, the shared decision making is coming together, two words coming together, the patient word, which is focused on the personal life, the physician, the health provider word, more focused on the healthcare provision, and these two words are, characterized by values, background, motivation, different backgrounds, but they need to come together to reach an agreement on the best treatment in the best interest for the patient. But shared decision making obviously is affected by human bias, because we are humans, okay? So we are not machines. We are not computers. So when we sit in front of another person, it is two human beings discussing problems and treatments, and both parts are maybe influenced by bias and emotions. There are complex models explaining how emotions can affect the shared decision making at different levels. But human bias, which we need to acknowledge and try to minimize, of course, but are there, are also present in surrogate decision makers, who are, for instance, the relatives, could be the sons or daughters of the patient, and there are papers showing that surrogate decision makers were not clinicians. However, they play an important role in the decision making of the patient, especially elderly patients. They often come to clinic with a friend or a relative, their children, and this is very important because this patient need, let's say, an advocate to sit with them and to perhaps ask questions on their behalf, because sometimes patients are in shock and they are not able to fully grasp the entire conversation. And so it's important to have someone with you. And then perhaps, especially higher risk patients, when you discuss alternative or perhaps non-surgical alternative, they often ask more time. They go back home and they discuss the conversation with the family, reflect on what has been said, and then come back with a decision on the treatment. And the family or the surrogate decision makers have an important part in the decision. And there are papers showing that there may be bias on how for instance, different genders may be perceived with different frailties by non-clinicians, decision makers, which also are important to take into consideration for in the process of shared decision making. So it's more a philosophical, let's say, argument in which we need to acknowledge that there are bias when we meet and discuss the risk with patients, and obviously this need to be taken into consideration, and we need to try to minimize this in the best interest of the patient.